There is something curious about certain medications. The longer they have been around, the fewer questions seem allowed. Donepezil is one of them. Prescribed for decades, it has become embedded in memory loss treatment protocols across the world. A familiar name in clinics, hospitals, and care facilities. For many families, it feels less like a choice and more like a predetermined step after diagnosis. But here is the question that rarely makes it into the room. If this drug is truly indispensable, why does its role remain so quietly debated behind the scenes? This is not fringe speculation. It is an institutional tension. And it starts with expectations colliding with reality. When Donepezil entered the market, it was not sold as a cure. The promise was more restrained, a modest improvement, a slight delay, a way to help manage symptoms by temporarily boosting chemical signaling in the brain. That framing matters because it set the foundation for how the drug would be used long-term, not as a solution, but as maintenance. Clinical assessments over the years have consistently shown that, for many patients, the benefits are limited. Improvements, when present, are subtle, often short-lived, sometimes difficult to distinguish from natural fluctuations. Yet despite this, long-term use became routine, and that leads to a difficult question. Why does a treatment with modest, temporary effects remain so widely prescribed year after year? The standard response is familiar. It is the best option available, but critics argue that this explanation often shuts down deeper discussion rather than encouraging it. As prescriptions expanded, so did the quieter side of the story. Not public scandals, not headline-grabbing investigations, but clinical notes, regulatory warnings, caregiver accounts, persistent nausea, dizziness, fainting, sleep disturbances, changes in heart rhythm, episodes of increased confusion, especially during dosage adjustments. All of these effects appear in official documentation. What is less clear is how often they are emphasized during real-world decision-making. And here is the uncomfortable overlap. The patients most vulnerable to these side effects are typically older adults, often frail, and often managing multiple medications at once. They are also the primary recipients of Donepezil. That overlap is not proof of wrongdoing, but it is a pattern worth examining. Now, zoom out, because Donepezil does not exist in isolation. It exists inside a much larger economic structure. Globally, conditions involving cognitive decline represent one of the fastest-growing areas in healthcare. As populations age, the number of people living with memory-related disorders continues to rise. Estimates suggest that treatments and care associated with these conditions generate tens of billions of dollars annually. When medications, follow-up visits, monitoring, and long-term management are combined, within that ecosystem, drugs like Donepezil occupy a very specific niche. They are not one-time interventions. They are not short courses. They are ongoing, month after month, year after year. And critics of the pharmaceutical model often point out a simple economic reality. A treatment that manages symptoms indefinitely creates a stable, predictable revenue stream. A treatment that resolves the condition does not. That does not require malicious intent. It only requires incentives that reward continuity. This becomes even more evident when comparing how different countries handle the same drug. In some healthcare systems, Donepezil remains widely accessible with minimal restrictions. In others, authorities have reassessed its overall value, weighing modest cognitive benefits against side effects, cost, and impact on quality of life. In certain regions, funding has been limited or narrowed to specific cases. The reasoning is rarely dramatic. It is pragmatic. Limited benefit, documented risks, high cumulative cost over time. These decisions do not label the drug as unsafe. They acknowledge that its role is far more nuanced than marketing once suggested, but that policy nuance often stays confined to policy papers and advisory boards. it rarely reaches families facing real-world decisions. Another layer complicates things further. Donepezil is frequently prescribed alongside other medications common in older populations. Drugs for blood pressure, heart rhythm, sleep, mood. Regulatory bodies have noted potential interactions, particularly those affecting heart rate and blood pressure. Again, this information is public, but it tends to live in technical language, not plain explanation. The narrative focus remains firmly on memory. Critics argue this creates a narrow lens where cognitive symptoms are prioritized while systemic effects are treated as secondary considerations. For caregivers and patients, that hierarchy isn't always made explicit. Over time, something subtler takes hold. A psychological reliance on the treatment framework itself develops. Families often describe the same progression: hope at the beginning, relief that something is being done, then gradual uncertainty as visible improvements fail to materialize. Yet stopping feels risky, not because discontinuation is forbidden, but because alternatives were never clearly outlined. The medication becomes a symbol of action. Questioning it can feel like surrender. When treatment shifts from informed choice to emotional default, transparency starts to erode. None of this is an argument against medical care. It is certainly not a call to abandon prescribed treatment. Every decision should remain individual, medical, and carefully supervised. Incomplete context is its own form of risk. Donepezil isn't just a drug. It's an example of how modern healthcare often prioritizes long-term management over resolution, stability over disruption. Maybe the most important question isn't whether Donepezil helps a little. It is this: if the benefits are limited, the risks are documented, the global debate exists, and the financial stakes are enormous. Who benefits most when the conversation never goes beyond? This is the standard. Sometimes power doesn't come from hiding information. It comes from letting it exist quietly, where most people never think to look.